we'll start with the discussion, and then we'll go towards the capacity building, more specifically, this first collaborative coalition, or whatever we'll call it, which is as its early name as ECAN. I wanted to build on the exchange that happened in the last, let's say, month and a half. So indeed, we don't want not to recognize the work of many organizations already in the field. So what from WHO, UNICEF, the African CDC, as I said earlier, MSF, and many others, and local NGOs, faith-based group. And by the way, just so you know, there was another charity member, humanitarian member from the US that was reported infected and has been sent to Germany as of this morning. So this is kind of spreading beyond this inner borders we just mentioned already. So it's a second, not the first. So it's continuing. So all these persons that I want to recognize here is are putting their own health at risk to help. And just want to recognize that. But in a group like the one we would like to develop, we need to ask first a question: what can this volunteer-based, scientific-based network could contribute to? What is the existing effort, and what are the things that's missing? Joa identified many of them already in his presentation. And these your two slides, Joa, with the way forward are really explicit on that front. What we've also learned in the last few discussions with people in Congo and exchanging also with Joa is the lack of resources is huge right now. They're missing any type of PPE, from gowns, from goggles, from masks, to almost everything. It's something that is different from previous bigger outbreaks where the international community was aggregating in a faster way. Nicolas talked about the fact, for example, that USAID is not contributing as it was, but it's not only from the US. There was a reduction in contribution from Germany, France, from China, from so many countries. It's like an international trend right now. So that's increasing this void fraction in the response, and that makes it even more important for civil society-based organization. So one of the things that is already on the table. So we already have access to donors on the respirator or mask side. So N95 mask from Canada Masks, and Anthony, I don't know if Anthony is here, was invited, but no, I've seen Barry, which is here, knowing really well this. So, and they are available. These masks, just so you know, to make it clear, these masks are kind of expiring masks. So they have a 3 years lifespan according to manufacturing and regulation. But indeed, they're still in their boxes. They're still clean and ready to be used. And they could definitely serve in areas where they have absolutely a big lack of resources. Not only Canada Mask has already confirmed their interest in sharing, but we also have opened discussions with other groups such as 3M. But it's something to get the donation of the PPE, but this is a chain, okay? So from the donors to the distribution apparatus, and then to the local groups to receive them and use them in the proper places in the proper way. So this is beyond just the masks themselves or whatever PPE we're talking about. It could be whatever face shield or gloves, which are they have a big lack of gloves and even overall as well. So that would be a first thing. So this building of the three phases in the process is something that built capacity. So if we have established this route, whether it's with collaboration, doesn't mean a volunteer group will put them in their own ship and carry it with no, I'm not talking about that, but I'm talking about finding ways and source and collaborators that could do this distribution brokerage, custom things. And then on the other end, at the local level, finding where it will be sent, how it will be distributed, not only sent to a big warehouse where they're stuck there for months, but really the process for them to be spread into the local communities. And Joa mentioned it's many provinces right now, just in DRC. Joa mentioned another thing which is important. So when we're talking about distribution, we need to do that in the local languages. Indeed, DRC is mostly French based. There are other tongues, but French is one of the main language there. Uganda, it's in English. So we would need to have different versions of whatever it's the training material, the distribution paper. So that's the core for the discussions today and finding ways to achieve that. Um, at the same time as we're talking about communication, I just mentioned the local language, but there is a rampant misinformation, and it's not only in that area, it's everywhere right around the world right now. But this is impacting people directly, impacting and causing deaths right now because of this misinformation. So it needs to be addressed at the same time as these three, I would say, sourcing features are. So I just want to open the discussion and just want to see. Um,
Do
yes,
we
Yanir, you want to say something?
want to open discussion?
Yes.
Everyone can raise their electronic hands, or we can help. I don't know if the people have the ability to unmute. Is Sharon or others doing the unmuting, or should I?
They should be able to unmute if,
We
Okay.
can unmute.
yeah.
Okay.
Okay.
So go ahead, and Stefan, maybe you want to unshare your screen so that people can
Oh, yes, I will just do
get a
that.
little bit better.
Okay.
And then we don't have to spotlight now since we're doing discussion. So if we can do
Yes, it can be a group. Yes.
okay. So who
So,
has comments? Yeah, go
yeah,
ahead.
go ahead.
Um, I would like to say that maybe Nicholas or Stefan, you can talk a little bit about the group that is already formed while people are thinking about their questions or thoughts.
Okay. Nicola, do you want to, you already opened a bit on that before. You can just talk a bit further. I can also do it, but whatever you see fit.
Sure. So we have about 4 or 5 people who are currently really sort of partaking in the active group. But I mean 4 or 5 people who are who are sort of related more with the WHN. But we are collaborating at the moment with at least two, maybe three, also sort of local pastors in Congo. One of them is located out in the U.S. but has contacts in Congo.
Mhm.
And I suppose maybe to get the discussion starting, and I'm seeing actually in the chat, there's some great points that are being raised. I think that when we're trying to coordinate an endeavor, just like just the act of delivering sort of protective equipment, is understanding the interests of different stakeholders as well. In other words, is like for Barry's here, and I would like to get his insight a little bit of what sort of would be like in this case almost like the interest of certain like mask manufacturers, in order to sort of if they're in terms of what would be their like their interest in this, sort of better understand also sort of that could help maybe frame how exactly we would make this more of a sort of sort of a punctual and we would repeat this sort of this action every so often. Um, I saw in the chat also there was Abdul who mentioned the aspect of security, which is I mean I'm sure security with regard to the regimes in place. I'm sure this is also something that is to be considered when you just you know the mere action of delivering equipment. I'm sure that's also something that if the channels of delivery are disrupted by whatever sort of local groups are present, then you won't be able to actually get that equipment delivered to their sources. So these are all it's like that's the point I had not considered. I mean, these are all that's why it's just I think here just a brainstorming session to sort of better I understand what's at stake, what are the different implications. And then from there, we can sort of focus on how exactly to find solutions to those problems to get, just to get this particular project executed.
Yes, thank you, Nicola. So it's a group which was informal. The idea today is to structure it and find all the ways to support. And there was discussions with local, as I said, as Nicola said, pastors from French-speaking pastors from DRC, and also people in this in a group that was repeatedly met in the last 3 weeks. So we have a lot of points and questions. So I will start by giving you the microphone, Carlos. So go ahead, and then I'll follow the list as it is.
Yes, thank you.
Okay.
I mean, it seems from what Dr. Okechijoni mentioned, they know what to do. The problem is lack of resources and support from either local governments or international associations. I don't know how much USAID would have filled that in the past, and now, of course, that's no longer the case, and which alternatives there might be, either public or private, or let's say how to get the resources needed to the place where it's needed.
That's a good point. We need to extend our views and not using only the regular channels, whether it's USAID or others. We can also think about private partners and other partners. You're absolutely right, Carlos. We need to think outside the box now. Okay, so Joa, you wanted to add something, so I'll let you go ahead. You're still muted, Joa. It's not working.
Why don't we let Joe Vipond go next, and then
Okay. Yes, Joe, go ahead and Joa, you got it, I think. Just speak, Joe. I think it's fine. Okay, go ahead. You can.
I just wanted to share experience of the latest. There were some distribution. There were about 2 days ago, I think it was on Friday, the International Red Cross Red Crescent, Geneva, acquired vehicles, heavy-duty Fort Worth, to a tune of 20. And those vehicles were received here by the Minister of Health, Uganda, to forwarding directly to Ebola response team in DRC. And that was done and very smoothly so, because the vehicles are already on their way going to the area of the response. So I'm thinking aloud that one, our Congolese colleagues with whom we are in contact in DRC, if they are listening, they can give us ways and means of receiving these things on the Congolese side. But in case they find that there are some difficulties and also distance, you can imagine if these things have to reach Matadi, and from Matadi to Kinshasa, from Kinshasa to the Eastern DRC, that's long. Whereas if it is forwarded through Uganda, it is a shorter distance to the area of response. Therefore, I'm suggesting that in the case we have already assembled and known and agreed the shorter distance to the response area is through Ministry of Health Uganda and directly to the response zone in Congo. That is shorter and much easier than the other longer distance. You know, Congo is very big, and the disease is expanding, and we don't have time. That's what I wanted to say for the time being.
thanks, Joe.
Yes, that's an important thing. We not always realize as how big DRC is in terms of surface, and you're right. Uganda is more concentrated in the small, so there might be this distance important feature. But you said also just one point that the Minister of Health, especially in Congo or both in Congo and Uganda, are responsive and collaborative. Is it both? Just want to clarify, Joe, or just one of the two? The two? Okay, good. Thanks. Joe Vipon, go ahead with your
Yeah,
point.
yeah. Thanks for this discussion. It's super important, and I just wanted to relate a little story and get your group's feedback on this, and recognizing that sometimes I have tunnel vision, and so therefore I see things through the world of mask. And so when early on in the Ebola outbreak, we got infection protection and control guidance here in Calgary, Alberta, where I live, and we were told that medical masks were the required masking if we were to see a patient, and certainly that seems to be the WHO advice, not to use a respirator. I confronted our infection protection and control people, and they said, well, the reason for that is because there's evidence that you can self-contaminate in removing an N95 mask, and that therefore they were more dangerous than medical masks. And so that has resulted in a situation where you see people who are fully PPE. There's not a single piece of skin showing except their face, because they're breathing through a medical mask rather than a respirator. And so I fear that you could provide them with all the respirators in the world, and they won't be used because there's the chance that either they will be told that medical masks are adequate, or alternatively, that it's actually more dangerous to use a respirator, despite the fact that we have, healthcare workers falling by the droves. So, thoughts on how to remedy that situation?
That's a good point. There's no, I would say, science backing this statement that was said by the authorities in Alberta.
I couldn't find it.
So it will be needed that training and science be explained, and that's why when Joa talked about proper languages in the region, it will need to be explained. You're right. There might be some resistance from some authorities, but in the field, the feedback we've got so far is they need those. So they're asking for those. Maybe some groups, some healthcare authorities might be resisting, but the need is beyond just that. It's either in local communities. So it's essentially to serve those which have not access to mask at all. And anyway, so probably that might resolve by itself, but it's important that they are not just coming like a box arriving from Amazon. It's definitely coming with support and interactions with the local communities. One of the reasons is what you said, that we don't want these masks to stay in the warehouse because they don't use it for whatever reason they're coming up with. I'm talking about probably the authorities like you've seen in Alberta rather than the people in the field themselves.
On that point also, I noticed that in Julie's slides, there were pictures of people that were wearing sort of full protective equipment, and I noticed that they were wearing N95 masks in those pictures.
Yes.
Would there be maybe if there was a collaboration with the minister in Uganda, we will reach the Minister of Health, maybe we can ask what exactly are the standards, so that there isn't any sort of reluctance, prior to shipment. We can say, what exactly is the standard protocol in Uganda and in Congo for that, so that as we there won't be a roadblock with regard to what is the protocol in place. Yeah, thanks, Jeff.
As soon as it's sent with the proper support around the PPE themselves. But thank you, Joe. And thank you, Nico. So, Claire, you want to add something?
I was thinking about how, especially in the US, we have a lot of mask blocks that donated masks to local communities, and I doubt that many of them would have enough on hand to take care of their own community and provide a very significant amount of masks. But I wonder if we could collaborate with some people who already operate mask blocks, who have contacts and know how to source masks because they already do it for their own communities.
Very good idea.
Yes, it is. It is really a good idea, Claire. So thank you for the comment, suggestion. So, okay, Abdul, you wanted to also add something?
Yeah, thank you very much. Actually, I work in Congo for 5 years. I was based in Goma, so during the last outbreak, the biggest outbreak, so I was based there. There is security challenges, big security challenges, especially in the epicenter, in the Bini and Bunia area. There
Mhm.
is Al Qaeda affiliated group, Islamic State affiliated group. Also, there are insurgent group with due to the regional geopolitical rivalry there in East Congo. So this is a major challenge. Security is a major challenge, and because that is the reason the current state is also the areas affected. It is controlled by the insurgent group. How to do this one? This is a big challenge. But the good thing is that there is a UN multinational peacekeeping missions, about 15,000 UN forces based in Goma, covering the whole area. But what I think the major concern is now the issue because USA and CDC no longer coordinate and collaborate with WHO. Because the last time they contained that outbreak, there was strong collaboration between CDC and USA. They were funding, they were on the ground, they were providing all the support. But now that issue, the global governance level, that there is no collaboration. So WHO is now working with the willing donors and also with the African Union CDC in also local institution. But I think major funding is required to how to engage CDC actually to collaborate to work more with WHO if we really want to do a big thing and contain the outbreak. Thank you very much.
Thank you, Abdul, and great to have your comment directly from what you've seen in Congo itself. Absolutely pertinent.
I want to
Yes,
interrupt for a moment the chain here because
yes.
Francois is now in the room. He was
Oh, he's arrived. Okay, good.
uh,
Francois, Father, you can present him, Yanir, if you'd like. But we had reserved some time for you to give us a DRC context and specific things. So I don't know, but Yanir, go ahead, continue with presenting him.
I just wanted to see if he could come on and speak. Francois, can you hear me and speak? He may not be
Okay.
ready yet.
So Francois, you have a special pass. So whenever you're able, you want to jump in, just raise your hand. We'll let you speak about the situation you see from the Congolese perspective. So anytime. In the meantime, I'll let our other colleagues exchange, and we'll continue like that. Okay, John, you wanted to add something.
Yes. I did a World Bank health mission in Zambia in the early 2000s, looking at exposures. The country was trying to turn over its copper smelting to private firms. But as a part of that, I worked with physicians and economists, and and then in another part of my career, when I was at the Department of Justice, BOP, I worked with United States Public Health Service professionals who were dispatched in the 2018-2019 period. And they mentioned the lack of physicians in the country. And my experience as well, going to different villages in Zambia, the health resources are really small. Mm-hmm. And so when I saw those statistics about the healthcare workers, one figure was it was 32 healthcare workers had died, and Dr. Okash had mentioned that it was 75. That's pretty huge. But I'm going to pivot a little bit and put on a futurist hat as well as an industrial hygienist hat. And the hierarchy of controls for industrial hygiene is elimination, substitution, engineering controls, administrative controls, and then PPE as a last resort.
The last resort. Yes.
And I saw in the chat that you are doing work with the Gates Foundation. And the reason why I mention that is if there is a connection to AI and robotics, and I'll just throw it out to the group, a possible solution, again, with the lack of USAID and other resources from other countries that we've had in the past, and that was mentioned, is to possibly substitute and thus eliminate, in some cases, human healthcare workers where it can be. And the humanoid robots that I have seen demonstrated in, like, there's hospitals in China that are completely devoted to AI, where you have AI doctors, AI nurses. It's quite impressive. And these robots, whether it's Unitree or Optimus, they can learn from human beings. And a possible suggestion might be, how can humanoid robots be trained, incorporated with human healthcare workers so that they can do the contact, the things that put healthcare workers at risk. And then one would need to incorporate some sort of a sterilization step for the robot after it's been used. But this could vastly expand the amount of healthcare resources that you have, robotics combined with human workers, and thus either eliminate or reduce the risk. So, but I personally do not have a contact that can help with that, but the Gates Foundation and others might be an avenue to explore, to try to get those robots into the field, and building on experiences of countries that have incorporated them very strongly into their hospital situation and healthcare situations. That's all I.
It takes a big mix of solutions to fit with that, and definitely you're right. AI or robotic can definitely be part of it. It needs resources anyway, but with support, whether it's the Gates Foundation or others, it might be. So it will be to put that in the funnel of different options, but we'll need many. So thank you, John. That's a good idea. Ram, you wanted to add something.
Yeah, just a quick point on misinformation. And I was talking to some folks at UNICEF recently. They've gotten quite good at tracking misinformation. They have all these like rumor tracking tools. But I think the real struggle is identifying which rumor or myth needs to be addressed and how. And more often than not, it's at the front line where people, come and share some of this misinformation or myths. And the general tendency of healthcare workers, I'm going to use your word, Stefan, to say that there is no science backing this. And it just doesn't work. It's because, different population segments are coming at this from different angles. And you need kind of a more empathetic conversation where frontline workers probably need some scripts and tools to engage. Otherwise, because of paucity of time and lack of capacity, they tend to be quite dismissive. Yeah. We're doing some bit of work on that. Happy to share once we make some progress.
Good. So happy to hear that you're interested, and it's important you came up with something important, because we need, at the same time as we're coming with, I would call that material or physical tools, we need also to deal with the this mistrust problem, which is coming often from misinformation and beyond. But thank you for that comment. Margarita, you want to add something? And I just want to say that you're part of this initial group that exchanged in the last few weeks, and thank you for that. So Margarita, if you want to add something.
I just wanted to say that with the WHO, which I also put into the chat, I'm concerned about the recommendation for just medical mask in the fact that did they talk to, say, Barry Hunt, Nicholas Smith, like Naomi Wu, Corsi, and all the major industrial hygienists, because, like, based on my training, medical masks are great in a way, but really we need the elastomeric respirators, N95s, the poppers, the powered air purifying respirators, and the SABAs, the supplied air. And Mr. Barry Hunt could, he has better experience and knowledge than me, and he could expand that. Even that would be even better.
Barry, I don't want to put you on the spot, but if you want to respond to Margarita's point,
Sorry, I'm
don't
not trying
hesitate.
to, because he's the expert and
That's
the
but your point
major
is important,
guru.
Margarita. Thank you. Barry, if you want, you can jump in. If not, Yanir, you wanted to say something, so I'll let you. And if you change your mind, Barry, just ping and put your name on the list. So Yanir, go ahead.
Yeah, so yeah, of course, Barry is more than welcome. One thing that I wanted to say is that a fair amount of the framing of these discussions are that it's far away. But in the disinformation side, a lot of this is happening through the usual social media.
Yes.
When I inquired about what was the social media, what came back was the same things. Facebook and TikTok and the usual actors. So the fact that that can be engaged in or with is something that should be considered as part of the discussion of the effort. And Father Francois is having some technical difficulties. I hope he will be able to join. If not, we'll look for another opportunity for him to share his thoughts about what's going on. And I'll hand it back to you.
Absolutely, Yanir. Father Francois will have other opportunity. And I will just share my screen 1 minute because we're at this other level of discussion, and that's where there will be other possibility for other contribution by everybody. I've talked about the ECAN, so the Ebola Collaborative Action Network that we could start from the On Politics with the support of the WHN, which started it. So this is all from early discussions. Everything here can be modified. It's more to, oh, Francois is coming back. So this is to be organized and prepared by a group of persons that will be volunteering from here with the people that are already exchanging. So Kevin Edges, which is from World Health, the Workplace Health Without Borders, or Goja Gasperovich, developmental biologist, Margarita that just talked. We had, as Nicola mentioned, also collaboration from Father Faustin, Father Hubert, and Father Francois. You can definitely speak if you're able now. I see you've been back in, so if you're capable of speaking, I can let you the microphone. In the meantime, the next step in our discussion is capacity building. First thing would be to build this volunteer-based organization. Whether it follows this proposed mission or not, that's not critical at this time, but we would need to discuss what it could do. ECAN being just a proxy to whatever name we'll have down the road, so don't be stuck with the name. It's not important. What we should avoid, so what we should do, concentrate on, and what we should not, and let to other groups, and who needs to participate as a wide group. So I will stop sharing here. You've heard the question, and I'll put them in the chat. So if you're, that would be easier than having the full screen. So that would be the next layer of discussion. So we already had a few of the items that were mentioned in the last few minutes were definitely in the what we can do or what ECAN can do, and the things that needs to avoid and or not necessarily avoid. I think that the threats in preparing, like for example, the example Joe Vipin mentioned with the the respirators, even in Canada, according to the Ebola response, which are focused on surgical masks rather than the real respirators. So this is an example, but there are many other things that can be avoided. So I don't want to block you, Father Francois. I don't know if you're able to speak right now or not. If not,
he came in and then left, so I assume.
you've I that's what I was re-looking at the list and I was no more seeing it. Okay, so anybody wants to add or point, and Sharon, by the way, I don't know if you're able. I've exchanged, but I have not received the feedback. You're able to make, or Katie, or even Vincent, to make some sort of Google form that would allow people just to say they would like to participate in the next exchange. It's not a lifetime contract. It's more like we'll have further discussions down the road to get more concrete on this, and also allowing at least this first thing that we would be coming up with, the PPEs we were talking about, and also drafting the structure of such a response. Jeffrey, you wanted to say something. Go ahead.
Well, thank you very much. I really am excited about the discussion, and I'm humbled by the people that have firsthand experience in Africa, of which I have none. But I speak as a public health epidemiologist and sociologist, and I would harp on the items that you presented involving basic public health strategy at the community level. That is, especially in response to the cultural response to the management of dead bodies in that area of Africa, which is a highly potent way of spreading the disease.
Yes.
And the often violent response of people in those communities to basic hygiene efforts. So looking at that particular aspect of the problem, I think the paradigm that you lay out mentions it, but is deficient in details about on-ground, in real-time community development work by influential leaders. Now, those may be the insurgent militarist groups. They may be self-directed leaders in resettlement camps. They may be local religious leaders. But I think that there needs to be an emphasis on organizing and educating and mobilizing, if you will, influential people at the community level to change the level of trust and misinformation so that we can build a public health model from the ground up, which will meet, if you will, the strategies that you've recommended from afar.
Let me actually add something to that, because I don't know, Joa, you would like to say something about it, but the situation on the ground in West Africa in 2014 had the same issues with the burial customs, and it was overcome, and the community efforts were possible to make. Again, the difficulties here are not just that, but the fact that there's conflict on the ground. So I think that the basic frame is present. It's really a question of how to engage it to happen in this particular environment. And Joa, maybe you would like to add something, because of course this speaks to your experience, if you have a moment. I don't know if you can unmute quickly.
You just retry unmuting, Joa. It didn't work.
Yes.
Okay, good.
Thank you.
Perfect.
I appreciate what Jeff, the colleague, that just said. Now, our problem in West Africa, we're lucky, very lucky that we, at that time, the conflicts were no longer there. Were just the country was just coming out of post-conflict. However, it was the first time this disease appeared in the West African region. They just used to say, in fact, when we reached, they were saying that is the disease of East Africa, that is the disease of Central Africa, that is the disease of the Congo. And they even ended up saying that Ebola was not real until when it started killing almost everybody who came into contact with the persons who were sick. So the health education team was very, very important. The contact tracing team, that is the epidemiologists, were very, very important. And then working together with the persons, the health workers, whom we were able to train within that short time, and they joined us, and the community persons knew them, was very important too. Now, the Congo, where we are now, as I said before, the big challenge is conflict zone, where there has not, although ceasefire has been requested, we are faced with we are in a situation where it is the first kind. It is the first time where it involves at the same time the conflict zone. There is hunger, there is mistrust, there is displacement, and the next one is that they even attack the ETUs, Ebola treatment units, ETCs, Ebola treatment centers. And for reasons that are better known to them, the misinformation is rampant. Can you imagine that someone records a situation which is partly true, and he inserts some misinformation? There was one that was running around where they were saying there was no dead body in the coffin. It has been verified and found that that was the misinformation. You can imagine. So the social media has again complicated, is a confounder. When we were in West Africa, social media was not the question. We had Facebook for communication, but it wasn't at this level of misinformation for the reasons that the misinformer is known only to the misinformer. Therefore, we need at the government level to be really assisted to clamp on these the social media, which is now rampant and misinforming, and this is seen in the zones where the response is taking place. So for the time being, there are a lot which we can say, but for the time being, let me stop there and let the colleagues continue. Thank you.
Thank you, Joe. You were right pointing at that risk out. By the way, just so you know, our Father Faustin and Nicola, just add to it if you see things. They reported it a week ago or 2 weeks ago, I think, that one healthcare center in Butembo was set on fire by a local resident because of misinformation. They thought it was a kind of plot from whatever Western countries, and it was a local community-based healthcare center, which was set on fire. So they were able to extinguish it. The center is still working, but that was that went up to that level. It's not just they don't necessarily use protections or whatever. It's also they would cause risk and damage to the current lacking resources. So yes, Naomi. Yanir, you want to talk before or
let me only go first, and then we are coming to the end of the workshop
Yes.
period. Just to let you know, the next stage is about the teams, and let me just say that one of the possible things to do is to go into a breakout room to talk about the Ebola outbreak and efforts in that context. But there will be other choices, and so we will be moving to that stage. But first, Naomi, go ahead.
Yes.
I've been thinking about your question, Stefan. What should ECAN do? What should ECAN avoid, and who needs to participate? And I have a few thoughts on that. In terms of what ECAN can, and I like the name of the organization, but someone else will make that decision. Is to make sure that what we can do is, before we dump too deeply into anything, to make sure that we have a full picture of the landscape of what is out there, both in the African countries involved and also in Western countries that are, and Eastern countries possibly, that are helping with this, so that having a full picture will be helpful, and that will help us to with the next question, which is what should we avoid. And that is, I think, with that fuller picture, we can avoid duplication of effort, which is not the same as redundancy. Yes. Right? We do need some redundancy, but duplication, uncoordinated duplication, is a waste of effort. So part of our job in this group can be to really make sure we have that full picture. And the last question of who should be participants, who do we invite to the table, who is in this conversation, and I would put out a few possible, healthcare providers, etc. We all know. I think it would be interesting to see if we can get some representatives from the parties that are in conflict, that are making this all so much more difficult, and they can still conflict over here and be able to come together to talk about a solution to this problem that is affecting all of them over here. That won't be easy, but I think it's worth considering doing. I think involving, as Father Francois is, religious leaders who, first of all, have connections to the community and can get some buy-in, and also who may be able to address the issue of the funeral problem in ways that us coming from the outside, we just have no way of doing that. But within the system, there may be ways of addressing that, and we need to include them at the table. And obviously community members, people who are involved just on the ground in the community, professionals, epidemiologists, lay people who are community leaders, to be involved in this conversation in a broader way. So those are just a few thoughts.
Important thoughts,
Stefan,
Naomi. That's
sorry
absolutely
to interrupt.
important.
I just wanted to let you know I put that little form in the chat.
Yes, I saw it. Thank you very much, Sharon. It's you made it quickly, so thank you very much. Okay, so Naomi, you're right, and you it's absolutely necessary. We have local people involved in a group like ECAN or whatever we call it. It's absolutely necessary if we don't want to be detached from the real needs. On top of that, what you add is another layer which I've not seen before, but it's important to have even the parties that are fighting. And so M23, so the March 23 rebellion, the one that's related to, as Joa mentioned, to Al-Qaeda or ISIS, and the government authorities from both countries, but also some religious leaders. So that's absolutely important. We have in a group like that, a good representation of all this. It's not an easy thing. You're absolutely right. But they're fighting a common threat, and this threat is Ebola. Right. Beyond their political views, beyond their whatever.
Exactly.
The virus doesn't mind if you're talking for this group or that group. If it reaches you, it will do what it's doing. So that's an important point. And I'm about to close, Yanir, and Nicola, you can add whenever you want on the closing. So the key thing here is building a structure that will last. And for it to last, we need things like local connections. We need experts from a diversity of background. We need organization, whether they're private or public, like Carlos said earlier. So, and we have an example. So the first action of such a group would probably be to be able to source or supply masks, which are coming from private organizations. So it can be public, private, religious group, anything. So we should think of being more inclusive than the opposite. And that way, that will be more resilient down the road, by the way. So it's resilience built in from, sorry, and then helping up to the people in the field as well. So you've seen, and Sharon mentioned it, there is a simple Google form where you can just let your name. This informal group has already started.
For what it's worth, I can't open that form.
It's
I
not
don't know if
working.
anybody else tried it, but I got an error message.
Maybe the link is the wrong link.
Okay. I can open it, so there might be
try one more
Might be
time.
the browser.
It
Try
might
one more
be
time.
yes. It needs a Google account just to make it easy, probably. But anyway,
Can't open the
try
page.
it.
The operation couldn't be completed. No space left. All right, so I probably need to just use a different browser. Okay.
And plan B, and sorry, Sharon, to put you on the spot still. So if someone is not able to use the link, you can just send an email to Sharon.
Yes, I'll put my email in the chat.
And you can add it to the list that we'll have built. And then we'll start to build that from this. And it's as I said, for something that will need to last, because we're in a big Ebola outbreak. Nothing appears to say that it will be the last one and it will resume very quickly. That's something that's still in a steep increase right now. Joa shared and I shared numbers. So it's by the day that we add dozens and dozens of that still. And now, as I told you, a couple of humanitarians and others are already starting to extrapolate that to other locations. So, okay, that will be all. Nicola, you want to add something before we end up?
Just maybe a few points is
yes.
I think it's here based on the magnitude of the task, right? It's also finding something that we can digest as a first first step. Obviously, I agree. Naomi, thank you. It's always a pleasure to see you. And in the discussion, I think as you mentioned, is understanding what is happening on the ground. Joa's insight is critical. That of the other pastors is also essential in establishing this. Also there's the fact that obviously the World Health Network, where a lot of us are sort of, related to it, our focus was on respiratory protection because of SARS-CoV-2. So in other words, this is a pivot. We're talking masks simply because our contacts are in masks, but obviously there are gowns, there's gloves, there's a lot of protective equipment that is essential also here. So it's just about, again, establishing new channels, branching out, also I think broadening our vision as well. In other words, this is part of the activity of tackling a completely different type of epidemic, a different disease, and how exactly do we get there? How do we establish the necessary tools, network, and resources in order to do so? And I think that's why we'll start with this. We'll have this almost like this prototype initiative, which then will set the groundwork for future. Because I think this epidemic will last, unfortunately, for quite some time. So we're going to need to put some channels in place.
So thank you all. That's the end of this workshop, but the beginning of the work. Okay, thank you.